Good morning. Thank you very much for staying by the very end of this conference. And this is the last case presentation, and we will take a look at two cases that could be very confusing and also can be missed if you don't pay attention to the details. So details is very important in our field, and that's going to be a demonstration showing that. So we had this patient who was inpatient secondary to the the problem that was not related to the fetal heart, but as soon as we scanned her in the hospital, we looked at the heart very carefully as a part of the evaluation. And this is the 4-chamber view that we were able to obtain on this fetus in the vertex presentation. You can see that the left side is down here. And if you look at the 4-chamber view, you probably would agree that who thinks that this 4-chamber view is normal? So everybody thinks abnormal? Okay, so that's probably the 4-chamber view looks okay. So that we talk a lot about 4-chamber view, and I can't see any specific pathology for this. So, and now we are moving to the left ventricle outflow tract. Any ideas? Should we stop here and look in more detail so we can go to a different view? Do you like the view? Is it okay?
Aortic valve.
Sorry?
Aortic valve.
The aortic valve. What's wrong with the aortic valve?
It's not opening fully, it's thickened.
Yeah, so it looks thickened. It's more echogenic that you would like to see. And it seems that the leaflets, the excursion of the leaflets is limited and the valve is not opening all the way. So what do we want to do next? We want to put color on, right? And here is the color Doppler of the left ventricle outflow tract. And in this position, you can't see any significant turbulence at the valve or any specific features that would tell you that the baby has the aortic stenosis. So, but also it's very useful to take a look from a different angle, and this is the 5-chamber view, and then the baby turned a little bit. And in this view, it seems that there is some turbulence occur at the level of the valve in the ascending aorta. And then you suspect that to make sure that you're not missing the mild stenosis. It's very good idea to take the spectral Doppler of the valve, and here you can see that the velocity is increased. So we're in about 3rd trimester in the pregnancy, and velocity on the aortic valve at that time should be about 100, not more. And here we have that the velocity is increased pretty much twice. So here it might be some obstruction, and that's why the turbulence is a real one. It was confirmed by the spectral Doppler. So now we are looking, trying to take a look at the valve itself, and the best view is the short axis at the level of the basis of the heart. And remember that we're supposed to see a very nice Mercedes sign. And here it seems that there are 3 leaflets, but if you look in the cine loop how that leaflets are moving, you can see that these two kind of stick together and act as one leaflet. And in this case, our diagnosis is going to be, what do we suspect here? So we suspect that it might be a bicuspid aortic valve, right? The mild stenosis based on that spectral Doppler findings. And then you suspect the bicuspid aortic valve. You need to pay very careful attention and evaluate very carefully the 3-vessel trachea view in the aortic arch. As we mentioned before, that the bicuspid aortic valve has a very high association with the aortic coarctation. So in here, we're not able to see any evidence of coarctation, even though if you take a look, here we can see a little bit of reversal flow. And again, in the 3rd trimester, you can see it not just on the growth-restricted babies. In this case, you can see that babies practicing in breathing very actively, and sometimes even the breathing can result in some reversal flow in the aortic isthmus, so that the best time for evaluation of the aortic isthmus, then the baby is not moving much and not practicing in breathing. And here is the evaluation of the aortic arch in the sagittal view. We can't see any evidence of coarctation, even though it's important to remember as soon as the ductus arteriosus is open, we can't exclude completely coarctation. So then you see bicuspid aortic valve. Look at those kids after birth until the ductus is completely closed and that you see no obstruction of the aortic arch. So the baby was born at term, and our diagnosis was confirmed by postnatal echocardiography. It was the bicuspid aortic valve secondary to the fusion of the left and right coronary cusps, and there were no evidence of the significant aortic stenosis or aortic arch abnormalities. So this is a parasternal view demonstrating the aortic root and the aortomitral continuation, and you can see that even postnatally we can see that the leaflets are thickened and the valve looks a little bit unusual. And this is the short axis view showing how the right and left coronary leaflets are fused together and act as one leaflet, and then we have non-coronary leaflet, and this is the bicuspid aortic valve. So this is just a diagram to remind how the bicuspid aortic valve may present, and this is a very common situation that initially this is the three cusps in the valve, and then for some reason there's the progression of the pregnancy, two of them would fuse, and that would result in functionally bicuspid aortic valve. And the situation then you have just two cusps from the very beginning, it's relatively rare, so it's important to keep in mind. So this child developed no coarctation and still under observation because has the mild to moderate aortic stenosis, and so far didn't require any intervention for that. So in the next case, the patient was referred to as the suspected congenital heart anomaly, hypoplastic left heart syndrome, and here is the four-chamber view. And if you look at this four-chamber view, it seems like then you look very briefly, it seems that it meets all the criteria for hypoplastic left heart, right? So we have a very globular left ventricle, we have the evidence of increased echogenicity, but then you look in more details, you can see that indeed the ventricle in the hypoplastic left heart syndrome usually has a very decreased contractility. So here we don't have evidence of the decreased contractility. Then we look at the apical view, we also see that despite that the ventricle looks very small, we still have normal integrate flow across the mitral valve. So the mitral valve is patent, and there is no evidence of significant enlargement of the right side of the heart, which is very unusual. Then we are checking the foraminal valley. And surprisingly enough, we can see that the foraminal valley, the flap is seen normally in the left atrium, so that confirms that there is normal blood flow through foramen from right to the left. Again, doesn't match the hypoplastic left, right? And this is the short axis view, again demonstrating that echogenicity involves just one segment of the myocardium in the septum and the papillary muscle here, but the rest of the endocardium and myocardium contracting normally and looks pretty normal. So that echogenicity involves just one segment, the heart, and this is also unusual. So and now we are looking at the left ventricle outflow tract, and surprisingly enough, we have no obstruction of the left ventricle outflow. We have a normal antegrade laminar flow across the aortic valve, and then we put all these findings together, despite that the very first impression tells us that it must be hypoplastic left heart syndrome. Looking at all those details, we probably not going to make that diagnosis. So we are moving to the free vessel trachea view. Again, we have a little bit smaller appearance of the aortic arch here and the isthmus, but still preserved antegrade flow in the aorta. And then we're looking at the arch. In the 2D, it seems that region of the arch look a little bit skinny, but then we looked in details. Initially, color Doppler showed normal flow across the aortic arch, and then late in the pregnancy, right before delivery, that area looked a little bit more stenotic, and they thought that over time, the changes in the size of the chambers and the perfusion probably resulted to the development of the coarctation of the aorta. So our diagnosis was most likely unexplained calcification or increased echogenicity in the left heart with potential coarctation. And our findings were confirmed postnatally. So the baby had just the coarctation of the aorta. And as you can see at the postnatal echoes, the echogenicity would persist after. But if you look at the size of the mitral valve, if you look at the contractility, that was normal. And there were a little bit of the insufficiency on the mitral valve, but that left ventricle was functional. And the detailed assessment result in the decision that we can resect the coarctation and try to make this left ventricle functioning and support the systemic circulation and trying to maintain two ventricular repair. So, and this is parasternal view showing that indeed the dimensions of the left ventricle, despite of that echogenicity, were normal, and the size of the mitral valve and the left atrium were appropriate for that time. And here is the right ventricle outflow tract showing a little bit dilated pulmonary artery, but nothing typical for hypoplastic left heart syndrome. And this is the aortic isthmus. We have a little bit of turbulent flow here, and definitely ductus arteriosus was helping the circulation, so that the gradient was about 46, so not such a dramatic coarctation, but the surgery was performed without any complications, and 3 months after that left ventricle was normal size and was functional normally. So what was the case? So we discussed that, and in the literature I found this paper that sometimes in the left ventricle we can see idiopathic calcification, and interesting enough that it could be viral and due to viral infection. And in our case, we performed a viral study on the patient, and she had positive IgG and IgM for adenovirus. And as you can see, the infections that can cause these problems to the left ventricle, so that was the adenovirus based on the literature. And we decided that initially what happened that was infection that resulted in that abnormality on the left ventricle, the myocarditis and development of the calcification, and then the reduced flow to the left ventricle resulted in abnormal perfusion of the arch, and that potentially contributed to development of coarctation. So that's why it's very important to keep in mind that anomalies could be due to the other factors, like not just genetics and abnormal development of the heart itself, but it could be secondary to the other complications of the pregnancy. And this is not the only case that we had during this conference, showing that that environmental factors are very important and each pregnancy is different. So pay attention to the details. That would be probably my best advice and take-home message, and think outside the box. Thank you very much for your attention. It was a pleasure to spend these 2 days with you. Thank you.